Good afternoon, everyone. Thank you for coming out to Pavilion A in this rainy day. It's really great to see each and every one of you here. So I want to once again extend my thank you for all of you being here. As many of you know, I'm Janie Heath. I'm the Dean at the College of Nursing here at the University of Kentucky. And we are thrilled to see such a great outpour of support for our Nursing Leadership Lecture Series. In particular, I'd like to thank our partners and nursing colleagues, including UK healthcare clinicians that are here. Thank you, guys. Our College of Nursing faculty that are here, as well as our wonderful students. And we've got some of our alumni and a wide circle of friends and nursing leaders in our community. So on behalf of my partner, Dr. Colleen Schwartz, our chief nurse and chief administrative officer here at UK Healthcare, we welcome a colleague who is very familiar with the Big Blue Nation, but has never actually been to Kentucky. She is well aware of our friendly rivalry on the basketball court, and since we are not in the Final Four together, we welcome her with even more of a full and grateful heart for being our Nursing Leadership Lecturer, Distinguished Lecturer this year. Dr. Marion Broome is Dean and Ruby Wilson Professor of Nursing at Duke University School of Nursing. She's also Vice Chancellor for Nursing Affairs at Duke University and Associate Vice President for Academic Affairs for Nursing at Duke University Health System. Widely regarded as an expert scholar and leader in pediatric nursing research and practice, Dr. Broome launched her research career developing and testing interventions designed to assist children to cope with acute and chronic pain. She later extended her area of research to ethics related in terms of informed consent and assent for children in research, research misconduct in clinical trials, and ethical dilemmas in publishing. Among her many accomplishments, Dr. Broome has served as president of the Society for Pediatric Nurses and has been on the boards of the Association for the Care of Children's Health and the Midwest Nursing Research Society. Currently, Dr. Broome is editor-in-chief of Nursing Outlook, the official journal of the American Academy of Nursing, and the Council for the Advancement of Nursing Science. She has been a fellow of the American Academy of Nursing since 1994 and was inducted into the Sigma Theta Tau International Research Hall of Fame in 2010. These are just a few of her many honors that have been awarded to her for her outstanding leadership. Dr. Broome currently consults in her spare time with a variety of schools of nursing and magnet-designated hospitals related to evidence-based practice programs, research implementation, professional development for nurses and faculty. She earned her BSN degree from the Medical College of Georgia, where I first met her when she was one of our distinguished alums, her MSN from the University of South Carolina, another connection point for us, and her PhD from the University of Georgia. So yes, she's got some Georgia roots. Sharing the stage with a national champion is always a joy and pleasure. So please welcome Dr. Broome to our Big Blue Nation at the University of Kentucky. Thank you.
It is a pleasure to be here. And I'm glad we're not in the, well, I'm not glad we're not in the Final Four. I shouldn't say that, right? We should be there. Kansas just did it better, I guess, just barely, but they did do it better the other night. I am going to tell you a little funny story about state schools. I am, as you heard, I'm a state school gal. I was also dean at Indiana University for 10 years before I came to Duke. So I'm not, Duke is private, all this other stuff is a little new to me, but a funny story about one of your faculty is Ellen Hahn was also inducted into the Sigma Theta Tau Researcher Hall of Fame the year I was. We were the first inaugural group. And right after, we had 13 of us, and right after that, University of Pennsylvania Dean, Afaf Malise, says, will anybody who's been to Penn, teaches at Penn, or graduated from Penn, please come down and take your picture? So guess who was left on the stage? Ellen and I. And looked over at her and I said, well, Ellen, I think we did okay, even without going to Penn. I love telling that story. Well, here's one of the things about fearless leadership. You have to get your titles right. And this is so me, not paying attention to details. The topic that you had out there as you came in, and I hope you did choose to come here to hear it because of that. But then when I got to putting the talk together, I thought, really what I want to talk about is how nursing has to change and how to manage that change. We don't have to change. We are in the midst of it. Whether you're in, how many of you are from the health system? Okay, wow. Okay, so you don't know what change is all about, right? Not at all. I spend about 40% of my time in our health system because of those other titles I have, and I am actually astounded at the rapid pace of change that nurses are expected, and physician colleagues as well, are expected to embrace. So I'm going to talk a little bit about that, but you know, it all starts with the nursing education for us in our discipline. So I do want to talk about how in the world do we take our important traditions and our excellence in education and be agile so we can prepare. It's all about the students. And just like in the health system, it's all about the patients. Well, in my side of the street, it's all about the students so that it can eventually be all about the patients. And I'm fine if you have a question halfway. It doesn't bother me a bit to stop. Now, this is my home. I know you know the Blue Devil. And I have become a rabid basketball fan, which is a shock to my husband because sports, I didn't even know how to spell the word. But I do. I tell you that it's good to follow something like that, right? So let's talk about a little bit of the trends in contemporary healthcare, because really, if we don't keep those in mind, we cannot serve our students well. And we now know that we're all being expected to manage health of defined patient populations, not to manage diseases. Those days, first of all, most diseases and most people, they have a lot of comorbid conditions, right? Diabetics have a lot of other problems. Patients with heart failure have a lot of other problems. So in the days of, and much less, the behavioral health issues that almost all patients with chronic illnesses are facing. So now we have to think and get more patient-centered and really look at the patient as a whole. I had an excellent question this morning about how do we educate nursing students and work with nurses in practice who now are managing patients across settings. How do we, it's not all about the hospital. And we struggle with that at Duke. How do we, our faculty are very uncomfortable with one semester being focused on acute care and the rest being out, the other three, we have an ABSN program, being focused on the community. And so none of this is easy, but it's something we do have to think about. What about, now you have interprofessional teams or something Kentucky does exceptionally well. You have education models that most of the rest of the, Duke is just now beginning to move into interprofessional education and care. There's a lot of faculty that do a lot together, but it's all, one-to-one, and it's all on the ground. But to do it as an institutional priority is just something we embraced last year. And so we have a lot to learn from places like the University of Kentucky. But care coordination, not so easy, is it? It's those handoffs are where all the accidents happen, right? And I remember one time reading that 85% of medication errors occur, when do you think? Shout it out. First 24 hours after discharge. And they're done, they're done by the patient themselves. They take the wrong dose, the wrong time, unfortunately sometimes the wrong med, all those 5 things that we teach about the rights. And are we doing anything? No, we're focusing a lot on discharge instructions, but we really have to get them into that safety net if that's what's happening. Improvement science throughout the health system. Health systems are phenomenally expensive operations. And we have, when I was at IU, I got to tell you, in Indiana, we were very reliant on Six Sigma and improvement processes. Duke has its own way of doing that. But the reality is we've got a lot to learn in every organization about how to serve the patient better. We tend to serve the health professionals in the system and not, usually that's around the physician, our physician colleagues, who we're trying to help to do the best they can, but the reality is it interferes with a lot of other processes. Performance and outcome measurement, benchmarks, and data analytics for, get the last 4 words, direct caregiver. And I say this at every opportunity. The days of ABSN or BSN students not having an analytic course are so over, it's ridiculous. Because staff nurses at the bedside, at least in the 2 systems I've been in, are actually responsible for some of those. How many of you have been involved in falls prevention programs? Yeah. I mean, you have to look at that data across all your other units. Sometimes you're running those projects. If you really don't know how to look and what the word benchmark means and how you look at that data and how do you know which quartile you fit into, much less how to get there, it's really just as important as some of the other things that we teach our undergraduates. And yet, I can tell you, that's not a very common course at the undergraduate level. The emphasis on efficiency and design thinking I think is very cool, and I think our students would be, if you don't know what that is, talk to your School of Engineering. They'll be the first people to tell you about that. Obviously, use of evidence-based, except it's really kind of dismal how much we should be moving beyond evidence-based practice. Nurses at the bedside are supposed to engage in evidence. You're a magnet here, right? Yeah. So you're supposed to be, and you have nurses publishing, you have nurses doing evidence-based practice in this place, if you're a magnet facility, and yet we're still teaching it in our DNP programs. I'm like, what is that about? So population health management, and this is a new concept, but again, if you just think about it, that patients belong to more than just one disease. And they are, in general, in their own lives, they're spending in their own skin. They are at home in their community. And so we have to learn to really get into that community and build infrastructure, which we decimated over 40 years ago. The public health structure has been gone. And we need to somehow invest. And what's happening is hospitals are doing that. So what are some of the trends in nursing education? All of these, this is a lot, I'm not going to read out. Some of the ones that really excite me are that the Macy's Foundation report came out and said that we should be using, that the health system should be using baccalaureate-prepared nurses in primary care and community settings to manage their own panel with a provider, whether it's an advanced practice nurse or a physician or a PA. They should be managing those patients who, and monitoring some of their values that come in and really making sure that they are getting and doing the kind of things they need to do. They might have a panel of, let's say, 30 patients, diabetic patients, as opposed to the panel of 300 patients that the physician or the APN has. So these are, again, this is team-based care. And teams working together with the same patient population to make a difference. I thought that, but interestingly, when you read the Macy's Foundation report, if you read it, 4 of the 6 recommendations had to do with curriculum and not in practice. Now, what I said at Duke before we instituted this rule, the reality is we're not going to go to all the trouble of putting this in our curriculum unless you have jobs for them, the handful of people who want a job in this area. And we won't do a capstone or a synthesis, I don't know what you call that in your undergraduate program. It's the intensive practicum, unless you're going to be open to hiring them, because we have other things we can do with them. And so they did it. And so we have baccalaureate, just started this past fall, baccalaureate prepared nurses who are now called population health nurses. Kind of really interesting stuff. The other thing is in some schools, we have focused for 40 years on PhD education teaching about clinical research, and we still need to do a lot of that. But the reality is somebody's got to do more research in nursing education, because I'm spending too much money, Janie's spending too much money on education, pedagogies that don't work, as well as other things could work. So we need somebody evaluating that. So why focus on innovation? Because what else would you, tradition is great, and there are some things, frankly, that I think we do in nursing education that we should never let go of, and things that we value, but sometimes those traditions and those values really get us stuck. And a good example is we still, to this day, at all levels of education, BSN, master's, DNP, and PhD, focus on tasks and not on the knowledge. We focus a lot on tasks. And knowledge is going to be, I'm an editor, so I keep up with this stuff. 2,500 articles a week are published in the biomedical journals. That's a lot of knowledge to get your head around. And not just in nursing, that's in all biomedical venues. But we have to come up with some new models to help our students. And frankly, they're a little ahead of us. But here's the dilemma. How many of you don't use Google? Not a soul. Okay. I use him all the time. Her. I should say her. But whatever, him, her. But I keep no facts in my head. I mean, there's too much up there. Anyway, and boy, our students, they have knowledge at their fingertips. Now, how many of you probably look about my age, but maybe you're over 40, remember library stacks? Yeah, and this is really old. I remember getting excited about the Xerox machine because I didn't have to sit in the library now and read the articles. I could actually Xerox them and take them home, right? Boy, are those days over, right? And I don't know if it is good news. It is. But it's been a real struggle for me to figure out how to work with this new generation in turn, because now I have to teach them how to manage knowledge, how to manage information, not how to get it, how to put it in their heads. That's not the deal anymore. It's really about, okay, and I learned in every education, all three, Marion, well, 4 if you count postdoc, I learned to deep dive. That's what I was told to do. You're going to become an expert, and you're going to deep dive. And then I went out into practice, deep dive. I wanted nothing to do with adults. I only studied children. If you were an adult, you weren't even part of I didn't care. If you were a child, on the other hand, I'd study anything that was related to you. It's just that Payne had a lot of interesting stuff about it. But it's hard, it still remains hard for me, and I want somebody to come out with a little webinar that will help me to think about this. How do you take a generation of people who have every bit of knowledge at their fingertips and teach them how to access certain information, how to evaluate the quality of that information, how to especially people always want to take on the new generation and say, well, they don't do anything. They don't move anywhere, do anything without checking with everybody else on social media. They look at all the reviews. Well, do you buy anything on Amazon without looking at all those reviews? If you do, you'll do it once. You won't do it again. So it's just a different way. I used to go to Consumer Reports. Now they go to 40 of their best friends, right, online. There's nothing to say one's better than the other. It seems to work for them. And my daughter has this whole science. She's actually a nurse anesthetist. But she has this whole science of how many negative reviews you should check and how many positive, and if they're long. I'm like, whoa, just tell me which one to buy, for heaven's sake. So we have to focus as we move from now being, and I didn't make this up, somebody else did. We have to be learning guides. We have to be coaches, not mentors. And I know that's a very controversial thing to say, but it is our role to be a coach and not a mentor, because the word mentor has taken on one person, one student, one faculty, sage. You do everything the way I did, and that's not. I can't create the future my PhD and DNP students are going to live in, because I'm not going to. And I didn't learn, the way I learned was a whole different, and you know what, I did really well, but that doesn't mean they're going to do really well if I insist they follow the same model that I did. So innovation, I have to admit right up front, I'm one of those people that I like change. Now, I'll tell you a little story though. I went to the University of Alabama at Birmingham, Associate Dean for Research, and I always said I was super innovative and I love change, and then they told me I had to teach an online course. If I wanted to teach the theory development course in the PhD program, which I had been teaching at other universities for, by that point, about 15, 18 years, and I was good at it. And I loved it. That's probably why I was good at it. And I got great evals, and I'm like, you gotta be kidding. But then it was a challenge. Okay, so I didn't teach it. I said, no, I'm done. I got enough grant funding. I got enough. I'm the ADR. I'm not gonna teach it. So then I went to Indiana, and I gave it, and Indiana has a distance PhD program. So the first time I said, okay, this time I'm going to do it. I don't know why I thought I had time as a dean to do that. But anyway, I took it on, and I thought, how hard could this be? do upload my notes, yada, yada, yada. And I remember getting back the first paper from the PhD students, and I went to Judy Halstead, who's an icon in curriculum. I said, Judy, is there something wrong with the Indiana PhD students? They don't, these papers are, I don't know, they're kind of low level. And she looked at me, she's not a funded researcher, and she said, Marion, you know, I've heard all my career you researchers talk about garbage in, garbage out. I think the same thing applies here. And I'm like, that's some brave, tell your boss. But I said, what do you mean? And so she said, you know, there's a whole science. I know you don't like that word when it comes to education. Actually, I've learned to like it. But there is a whole science to this online education and teaching students online. And it is not the same as being in the classroom. And I'm like, okay, I guess I got to learn some new stuff. So she gave me some books and all that kind of stuff. And now it is my favorite. I bore myself when I'm in the classroom, and I do teach in the classroom, but honestly, I get bored. It's because I don't have to think through everything up front. I don't have to put the emphasis isn't on the learning activities like it is online. It's really on what can I tell you because I'm in the classroom, and it's just different. So I'm just telling you that because I really resisted, and I was in a position I could resist because I didn't have to teach at UAB. And then I went to IU, and I felt like as dean, if I didn't teach at least one course a year, I couldn't tell people anything. So it worked out great because I had resources, and I was open. And when I didn't understand, which I often did not understand some of that education stuff, I had people I could go to that I trusted, and they kind of interpreted it for me. So I think innovation is critical on a number of different levels. First, it models it, right? That whole change that I went through, I can talk to our students about. And I said, I don't know what your version of online education is going to be, but it's going to be something. And you're going to say you're just one of those really flexible people, and then you're going to find all of a sudden you're not so flexible. So think about that, and think about what you, and I say to them, you're going to be a PhD from Duke University. People are going to expect you to, number one, know something, and number two, to lead. So you better think about, it's not all about you. It's about you have these other responsibilities. And I don't know what your world's going to look like. I don't think any of us know what their world's going to look like. But it's going to be different. And I think we have to remember that we're shaping leaders, not just students. You know, I say to our ABSN, we don't create leaders here. You wouldn't have come here if you weren't a leader. You just wouldn't have picked coming here. You could have gone to an ASN program still. You could have gone anywhere you went to, but you chose us. So we're going to give you our input, but you've already come a leader. So don't let us give you the Kool-Aid and believe that Duke's going to be totally responsible for you, because that's not going to happen. Now, it's another thing. Here's where we get into the change management. And I've learned a lot as a dean of 2 schools about helping people to change. And working with my colleagues, Marianne Fuchs is our system VP at Duke, and helping and supporting nurses and frankly our physician colleagues. Providers at the bedside are under a tremendous amount, whether it's at the bedside or in the clinic is irrelevant. They're under a tremendous amount of pressure. And the resilience, you know, you've heard there's a lot of, I would assume here, resilience is a really big program going on, and it sure is at Duke, because we have health professionals who are trying to use ineffective coping strategies because they got so much going on in their lives. Some of them are in patient care situations where they're probably not as safe because of their coping strategies. They're also, suicide rates are getting higher and higher all the time in our society, but also in healthcare. So we have people suffering who are taking care of those who suffer. So we have got to figure out in our classes, in our formative, our medical schools, our nursing schools, how to help students recognize their own vulnerabilities and their own strategies for helping them be resilient. So you have to be intentional, because they'll never be able to lead innovation and change without being able to. Because I got to tell you, that online thing, it was just a very threatening thing for me. It threatened all my values about education. It threatened my good scores, because I did not get such great scores, believe it or not, that first attempt. They were not good at all. Now, I didn't have to worry. I was already a full professor, you know, and I was dean, so like, or associate dean, like, who cared? But, ooh, they hurt. I mean, it had been since my first year as an educator that I had gotten those kind of evals. So it kind of hurts your self-esteem if nothing else. So here's what I tell our folks: pilot. Just you come in with a great idea and all your colleagues shoot you down. Okay, we have to have a clear proposal. We're not going to fund even with a small amount of money, which means even with your time. We're not going to fund anything like that without a proposal that's vetted by your colleagues. That means you have to take critique. That's not going to be easy. So, but I need to be able to think out myself what you're doing. And it sounds like a good idea, but I'm not so sure. But then when you do it, let's talk to your program director. Let's see if they'll allow you to just try this pilot. And the reason I do that is when I was an undergraduate instructor and assistant professor at the Medical College of Georgia, I had a very wise chair. And I did not get along with, I'm sure this doesn't happen anywhere else, but my teaching colleague and I did not get along. And we were both teaching pediatrics. I was getting a PhD in child and family development, so I was a developmentalist, right? I mean, I believe that kids developed, and she was disease system. You know, it was the cardiovascular system, and it was, you know, did all of that. So we were at odds big time in terms of how we were going to teach this course. So our chair said, you know what, let's divide all 30 students, get that. You can have 15, you can have 15, and my only requirement is you start with the same objectives for the course and you end with the final exam. But other than that, you all can teach however you want to teach it. Now, how many people tell you that nowadays? Here's what I learned from that. The mean score on the final exam was 0.8 points. 0.8, nothing. But guess what happened in between? See, because I thought my students were just going to be awesome. Because we co-created the exams, supposedly. I did half of them, she did half of them. But what do you think the students did? They talked to each other. They exchanged notes. Love it. You know, that's when you learn from your students. So the reality was, we could think all day long that our way was the best way. The students figured out how to beat the system. So, you know, but trying small things like that often teaches the person doing the pilot a lot, and it teaches other people a lot. So let people kind of step out there. Also, we can't change everything. And the reason we shouldn't change everything all at one time, and this drives me crazy about nursing. I'm married to a PhD in business. They never change their curriculum. I mean, they change their curriculum, but they never do it the way we do it. You know how we do it? We upend the whole thing. And then we spend 3 years voting on it, right? No, they don't. They change a course. And then they try it a couple of times. And they're not at all sorry when they have even changed the objectives. And I'm like, oh my gosh, you can't change the objectives in school of nursing. You have to go through all these different committees. So you better leave the objectives alone, and then you can do whatever you want to with the rest of it, right? Until they evaluate you. So, you know, there's people do different. And then have you ever taught in medicine? Yeah, syllabi are sort of, or anywhere, economics. Our syllabi are 12 pages long. Theirs are half a page. So seems to me they all get through school just really fine. But nursing has we really do a lot of detail. And then if the pilot does work, and it's got to be measured, and it's got, or evaluated, I suppose is the right word, and you've got to show, but then if it is successful, celebrate it. Now, you may not convince the whole faculty, and that's fine. All you want to do is be able to take a subset. But that's when you get into issues of students knowing what the other students did, and then they all want to be in the pilot, and yada, and that doesn't. So it really does generate some discussion. But what we cannot be is held hostage to one or two faculty who refuse to change. That's what I've seen in every school I've taught, is that one or two faculty continue to get their way while the other younger faculty can't make changes. And that is not, it just cannot be that way. And if you want, you can ask me what we do about that. So what are the facilitators? You know what? They're very soft facilitators. They're people who want to change. 20% of people, we know this from behavioral research, they're out there, they're going to go, they're going to, you know, that's what I thought I was, right? And then there's 20% of people who really don't want to change, but the other 60% are somewhere in the middle. What I find is if I talk to the 20% who don't want to go where we're going, I actually find some things that we need to consider as we make change. Those people are important. They usually have very good reasons for not wanting to change that we who want to change need to think about. Because if you left me to my own devices, I'd be out there changing things and then going, ooh, maybe we ought to do this or that instead. And that, you don't want to be in that. I also have learned a lot as a dean about effective communication. I used to tease the faculty at IU because I would communicate something. I do have a talent, a gift, or whatever, of being able to take disparate cues out of the environment and kind of say, I think this is something we need to be concerned about. The problem with that is when you do that, people go, just blow you off, seriously. They just like, oh, that's not going to happen because da-da-da-da-da. So I would tell them the first time, and I'd say, here's the cues I'm looking at. Here's why I think we need to think about it. But this is just time one, so I'm just laying it out there. If you have any thoughts about it, tell me. So about a month later, I'd get more cues in on to support my hypothesis. So I would then say, this is time two. Take 7 times for people to hear something before they even believe it. And why? Because the first time they go, that's not going to affect our school. That's not going to happen. Nobody's going to do that to the IU School of Nursing. And then the second time they go, and they've heard some things in the meantime that worry them about what's happening to maybe another school. Then they go, well, I guess it could, but probably won't. And then the third time they're like, yeah, maybe this is going to happen. And then the fourth time they're like, oh, Marion will take care of it. And then the fifth time, like, oh my gosh, this really is threatening. Now we got to do something. So it's slow. So you have to give a lot of communication, and you have to facilitate innovation. Some of the barriers, in my mind, the biggest barrier to innovation is you have people who have been very successful at doing what they've done all their careers. They're outstanding. They have been excellent. And now we want them to change that. Well, what is the first thing that's going to happen when you ask me to change something that I have been exceptional, and maybe even right now are still successful at? You're going to scare me. Because number one, I don't know what else you want me to do. And number two, I don't know if I'm going to be good at it. Just like when Judy Halstead said to me, garbage in, garbage out, I knew exactly what she meant from a research perspective and a statistic and data management perspective. I had no clue what she was talking about related to this online course, and I had to be embarrassed and say, what would success look like? What does a real, and then she opened up her course, and she showed me different tiny little things I could, not tiny, they were pretty big, but different things I could do. You know, at least they looked real big to me at the time. So I think when we ask people to change, we have to find resources, and I don't just mean money. Because sometimes you can have all the money you want, it's still not going to work. You really have to find other people they trust who will kind of walk this walk with them side by side and, you know, really just say, look, we have the intellectual, I say this all the time at Duke, we have the human talent and intellectual capital to do this. Whether we have the will or not, I'm not sure. So you need to tell me. But I know we can do it. I'm just not sure we're willing to do it. And then my last barrier to innovation is our regulatory bodies. Those of us in schools of nursing at the baccalaureate level who are trying to get our students educated to go out into the community, what exam do they have to take? That NCLEX. Now, all the researchers in the room, close your ears about this because it appalled me when I first heard it. They build the exam based on the last 3 years of practice. So the items on that NCLEX exam are based in the last 3 years of practice. Now that worked in 1969, 73, maybe on up to 95, 2000. It hasn't worked for a long time, and it doesn't work today because healthcare is changing as fast as you can blink. But when I go home, there'll be something else going on. And our students, to get jobs, are going to have to be able to grasp it. And yes, all of us have really smart baccalaureate students. We really do. But it is not right that we are not testing. If schools have moved, and it's been estimated, they've moved their curricula to 30% community-based care, and 90% of the NCLEX is still based on acute care models, how's that going to work? We know that even when they make small changes, it goes down. The scores go down. And frankly, some of us make our living by 100% pass rates. And even if you don't, if you get too low, the state's on you. So these are things, you know, they're system level things that we really have to kind of be thinking about. So changing educational practices, again, don't do it all at one time. Just like you wouldn't, I know you wouldn't do that in practice. You wouldn't just all of a sudden change everything, right? In fact, we now have these bundles of care, evidence-based, the bundles that, right? Somebody nod, right? So I'm sure I'm not out of touch. Okay, so we have these bundles of care, individual actions for a patient that are evidence-based, right? Now we're trying to test the bundles, which is, logistically amazing, because you don't know which one worked. And I'm like, why do you need to know which one worked? Because frankly, we said they're all evidence-based. So if they're all evidence-based, and it turns out the bundles usually are synergistic, right? They make for even better outcomes. I think it's a different question you're asking when you test a bundle of care strategies. But we need to know what to change and how much to change and make sure our outcomes are grounded in quality and safety, whether it's educational programs, frankly, or patient care problems. Because our med students, our nursing students, our pharmacy students must pass their boards. That's the safety part of it for them. And the quality part is what all of our commitment to excellence and rankings and all those things are about. And then knowing when to change and how late is too late. I worry about that with this upcoming 2025, because I'm going to hedge, as long as I'm dean, we're going to hedge our bets as to when we get rid of those master's programs. But I got to think, with the faculty, we got to think really carefully about when would it be too late. You know, we don't want to rush it. We want to, so all of that takes a lot of conversation, a lot of involvement from a lot of people. And then how do we know that we're effective when we make the change? And that I have found is the most effective strategy. When I was at IU, the first thing was starting pilots, but the second thing was saying to the faculty who are not engaged in the pilots, look, I have given them 6 months to do this, so we're going to measure them twice. They're two different, students, our cohorts, and they're kind of different. So we'll measure 2 different semesters with this pilot, and if it is not equal or better in terms of whatever outcomes you all choose, we will go back. That freed people up to say, okay. They didn't say they loved it, but they said, okay, let's see what happens. And I got to tell you a little story about this, because this even took me by surprise. So we moved to 12-hour clinicals with our students. We had 6 hours. So we went to one 12-hour day we had 2 12-hour days, but one for one course. Instead of the 2 days for one course, we went 12. And I heard someone that I never dreamed would ever, she was a dead set against that, dead set against it. And we were sitting in the lunchroom, and she said, we're really running into some problems. So I automatically think, oh, well, there goes that 12-hour clinical, right? And she said, because you know what we're finding? When they're in there 12 hours a day and they're with the same nurse, this was in the first med-surg unit, they've mastered the competencies by week 8. And we have 6 more weeks to go. So we're not real sure what to do with it. So I'm like, that's great news. If I were you, you can spend more time on your scholarship. Well, that was not the right answer. But anyway, I was like, wow, so glad we were measuring it. Because if we hadn't, we wouldn't have known that. She became a true believer after that. She just wanted to know she was an outstanding educator, had been teaching for 30 years, and she just wanted the data. And she wasn't a researcher, like we usually think of research, but she just wanted to know that that was going to work, so that her students were not going to learn any less. And in fact, she found out just the opposite, right? They reached the competencies first. So what are things that we've been doing? I need to watch my, okay. I might speed it up a little bit. I'll stop telling stories. So we're doing a lot. Everybody is. Standardized patients, which cost a lot of money, why I'm upset about that is because we don't get credit we can't use it for the clinical hours, just like simulation. I mean, come on, we have all this great technology and we're paying a lot for standardized patients and we have data. All health professions have data that shows that students learn more and more consistently if we do these new techniques, and yet our accreditation bodies don't want to count them. Come on, there's something wrong with that. iPad assessment for psychomotor skills. Cincinnati's doing some really cool stuff with competency assessment via distance students. There's a lot going on. Flipping the classroom. How many of you have been involved in flipping the classroom? Yeah, it's like online courses. It's a lot of work up front, but once you get that work up front taken care of, you really just are it's just so much better, because you can move to the guide by the side as opposed to the sage. You don't have to know it all, because actually our students in nursing now are smarter than they've ever been. Now, I know those of you who think you were the smartest. No, I don't think so. I'm not the smart. My group was smart, but not nearly as smart as the current students. And they bring so much to those discussions. Especially the accelerated students who come after a degree. Boy, they bring a lot of cool stuff. I think I want to do this when I retire. I want to be a standardized patient. Because they are very cool people. They are very smart. They should have been actors and actresses, right? Following patients across settings. At Penn, they put students into groups of, I think it's 4 or 6, and they follow families for 2 years. And you know why the family nurse, does everybody know about the family nurse partnership that started out of Goodwill? Oh, it's an amazing. It's all over North Carolina now. It's a baccalaureate prepared nurse picks up a high-risk 3rd trimester mother and comes to visit every other week for 18 months, have less pregnancies, children do better in school 3 years later, et cetera, et cetera. But guess what else they found? Grandmother's hypertension is managed better. Because grandmother's sitting there and says, can you take my blood pressure? The nurse is going to say no. You know, she does it and then refers her. So it is a phenomenal model. And the nurses that get in that practice, they don't leave. So it's, you know, following that's what we all do best. Nurses and physicians, and they come into healthcare because they want to be with patients and they want to make a difference. You know, here's the one caveat on all this. Once you do something strange, like a flipped classroom or case studies or standardized patients, or get all this resistance from students. They're like, whoa, we came here, what we hear at Duke, paying all this money for this education, and they're not teaching us. So we're very patient, we work with them, and look how much you brought in here. I know, but I'm learning that myself. Trust me, you would not learn it yourself. No. And again, I've already talked about the colleagues who have always been successful and should be proud of what they've done, but are struggling with the change. Student ambassadors, we are calling our students who are high adopters, fast adopters, student ambassadors in the 4 programs, because they can help the other students kind of settle down and understand things in much more different ways. Also, more cost-effective programming. I think that's not always true. Sometimes you have to put a lot of money in up front, but you can, in some cases, result in cost-effective programming. It's certainly more agile curricula. I think one of our big issues as health professionals is we've been entrusted with the lives of people all these years. This is not like a bank failure, you know, which is really nothing unless it's your money, I guess. But even then, it's insured, right? These are real people's lives, and we were socialized and trained not to be anything less, almost less than perfect. I mean, we're trained to have heavy responsibility, and we've sort of taken that throughout our careers. You know, we have got to loosen up on ourselves a little bit and figure out where we need to really be hard and where we can innovate, risk, and try some new things without, again. And sometimes I think it just really seems insurmountable. So let's just talk last slide, I think, because I want to leave room for questions. So what is it a college needs to support innovation in practice or any kind of culture and education? You know, first of all, you have to know it takes a village. A village is whether it's a unit in a health system, whether it's a department that in primary care, or whether it's a program faculty, it does take a village. And one thing we're working on really hard in most schools of nursing, medicine, et cetera, is the culture. Because we are still grappling with a culture that is very critical of each other, very less than. I have this hashtag this year that talks about building community. Our faculty respect each other a great deal, but that's not the same thing on a daily basis, but when it gets down to giving up what you hold near and dear to your heart, it's not so easy, and it's not so civil either. So we're really trying to work on that with our core values, et cetera. And not all of these suggestions I'm going to give you take a lot of money, but they do take some. So that's the other, I can't ask people to change without investing either in them or in their students or both. I just can't do that because without new resources to be able to learn how to do new things or take a risk or be given the time, it's really hard to try to do that. to just expect people to change. Again, that's a leftover from our health professions training, is you'll do more with less so because you're taking care of patients. Well, those days, that's just not how it works anymore. We have to have promotion criteria that value innovation, and we do that much better on the research tracks because getting grants require you to be innovative. You don't keep getting funded unless you're innovative. On the education, it's almost just the opposite. We want you to get good, always get good teaching evaluations. We want you to keep the rankings up. You got to do the same thing. So there's not that much of a reward system built in there. Again, funding we have a program that every time I have any money left over, I can keep it. Some schools you can't, you have to give it back to the university. And so I have a strategic fund. So I'll put that money in a strategic fund. We have so much a year, and faculty can apply for these pilot programs and try them out. But again, it has to be a well-developed proposal, and we won't fund it for more than 2 years. So whatever you're gonna do, we better figure out, are we gonna cut our losses, or are we gonna keep it going, or what are we gonna do? And people have learned a lot, I think. And they're grateful. One time the program was not very successful, and I think everybody was relieved to just let it go. Because sometimes we start, not a program, I'm not talking about a degree program, but this was a postmaster's or post-baccalaureate maybe certificate, and it just wasn't what we thought it was going to be. We had great dreams for it, we really thought it was going to work, and it didn't, and people were glad to let it go. But you have to have that permission. We're not going to do it anymore. It's okay. You have the data that shows us it's not working. And so I'll leave you to read these. The changes in regulations are up to deans. Deans have got to fight that fight. Those of you who are in the other professional associations have to fight that fight. We cannot do it by ourselves. And those professional associations have to start working together. Because a lot of times we'll get regulations on whether it's PhD education or DNP or whatever, and nobody's got the business case laid out. It's just like, do it, figure it out. And then we wonder why we have such variability. Well, I got to tell you, Duke and University of Kentucky and Indiana University can afford to do it right. Not every program can. And I know you can't afford it, but we can afford it more than other places can afford it. And then we criticize them because they're not doing it well. So I think we have to kind of, again, see this village as a profession and not just each individual school. Do they get the slides? Do you know? Okay, so there's other slides. I'd rather open it up. We only have 9 minutes left, I think. 4 questions. No question? Yeah.
You opened with some ideas for trying to get the hospital more invested in the community in order to develop those lines with the faculty and to promote that with students. Can you give us some ideas of how you do that? Because I feel like we're a bit flipped here, that we have a lot of shortages and a lot of sick care, but not as much community focus.
Right, there's a paradigm shift going on in healthcare, and some hospitals are coming to it faster than others. But for instance, at Duke, I'll give you a really good example. We, in our ED, and I didn't really know all this, but I sit at those tables. So in the ED, just like your ED, I'd be willing to bet a paycheck on the fact that you have a lot of behavioral care patients coming in. There are algorithms that say in an ED, anybody in here from the ED? Any chance? Okay. In the ED, you kind of want to turn these patients over, right? And then you can not only can you get them good care upstairs or wherever, or go home, but you also can bill, right, for them. Behavioral care we're coming in and staying there 3-4 days because we had no beds. They were too much at risk to send home for whatever type of disorder they had. That is a ton of money when you know that the average ED visit is $1,000. And you should turn over your beds or your rooms every couple of hours. That's a lot of money. That gets the attention of health systems. So Duke decided they looked at it for about 6 months, a year, like, gosh, this is not going away. Behavioral health rarely does, right? But these people were still coming. We still didn't have beds upstairs because we were bursting at the seams like almost every hospital. So then they've decided to go ahead and build and get permission for it and build a wing on one of our Duke-owned community hospitals that's just about 5 miles away for behavioral health. They'll have their own ED, get better care, have more specialists, nursing and medical specialists, and they'll have some bed to go to when they simply cannot go home. But those are, changes in healthcare are almost always driven by business decisions, and there is nothing wrong with that. And we all know that we have to move to population health management. It's a little easier, for instance, at Duke because we have Durham County. So we automatically, at IU in Marion County, there were 5 health systems, 5. So who owns which part of Marion County? And you know what? People move around all the time, especially the really high-risk patients. Those of you who are taking care of them, you know that their addresses are never the same. So, although they tend to stay in the same zip code, interestingly, is what I read. So health systems are going to come to that. If this one, I am sure, will be to that because the compensation models are changing, and we can no longer afford to treat people when they're sick. Because frankly, people are sick. If our society is 50% of our society, for instance, is obese, we know that obesity comes with a whole host of comorbid conditions. If we don't get on top of managing those comorbid conditions earlier, before they get to the point they are, it's going to cost the health system more money. And we're only going to be paid a certain amount to take care of people. So there you get the discrepancy, right? It used to be the more you did, the more you got paid. Well, that's not true anymore. Now you get a certain amount of care, hip for hip. We were an experimental, or whatever you call it, kind of a beta site for hips, taking care of hips. And that is everybody from the initial clinic in ortho all the way to the end. The dramatic changes that happened in access to the ortho clinics and how those patients are managed and rehab was brought in, actually it was awesome to watch the model of care that was put forth. And nobody's trying to save money. Nobody wants to hemorrhage money though. Because if you don't take care of them properly, they're going to be back in 30 days. And then you're not going to be reimbursed at the level that you need, that it cost you. So I think it's a lot. It may not be here as full-fledged as it is in some other states. Like New York has moved completely to a model of bundled care and different in population health, total. California, same way. So, those of us sort of in the Southeast take a while to catch up. But we'll be there, for sure. Children's hospitals lag 2 or 3 years behind as well. Any other questions? If I leave you with anything, and I know, didn't you have Cinda Rushton here? Yeah. Okay, so she talked to you all about resilience, right? And building resilience. But what I found is that as sort of the head of an organization in which people work, that we create our own stress at work, and then we all go home and have, a lot of us are caught between elderly parents and teenagers. Not me, I'm past that teenager part, and frankly the parent part. But a lot of my colleagues are caring for a parent with dementia as well as, young adults who are struggling on their own. That's a lot of stress. And so we've just brought in a wellness program. Didn't cost us much money. So we have a yoga class once a week, and it's actually remarkably cheap when you think about it, and people love it. And they're walking to Tanzania this 3 months, so we have this walking challenge, and it's not expensive stuff. We get brown bag lunch at the end. Big deal. But everybody gets a little ribbon they wear if they walk to Tanzania. And you know how many miles they did. And they compete among themselves. So there's a lot of different things, but I do think we have to take better care of ourselves. If we don't, we're not going to be much use to our students or our patients.